Well, good morning. It's great to be here in the Valley of the Sun. I just came from Chicago, where it's about 26 degrees, and before that, Toronto, which was actually a little bit warmer. I love it in Arizona. And I want to thank the program committee for asking me to speak this morning. Let me try to get this organized. So I'm just going to go through the American College of Surgeons Trauma Quality Improvement Program. So just by chance, I ended up being director of that program because I was involved with the National Trauma Data Bank years ago. And I'll just speak a little bit about what this is and what this offers. I'll speak about lessons we've learned in exploring high-performing trauma centers. It's very difficult to identify what makes a trauma center special, but we'll go through some of that. And I'll talk about organizational culture and how that relates to performance. So when we think of quality, there's actually three domains to quality. All of us think about low mortality and low risk of complication, but in fact, quality actually has three domains. There's structure, which means having all the right stuff, having the right people and the right physical resources to provide adequate care to the patient. Then there's the right processes. Do you have the right protocols in place, the right guidelines that you're following? Are you doing the right thing? And lastly, there's outcome. So outcomes are only relevant as a quality measure if they're modifiable. So a patient who comes in brain dead after a hanging, for example, it's not a modifiable outcome. It's probably not relevant to study that and look at the quality of care when you're focusing on certain types of patients. So there's actually three domains to quality. We always focus on outcome, but structure and process are also important. When you look at how the ACS, the American College of Surgeons, goes ahead and verifies trauma centers, this is the most recent resources for optimal care of the injured patient. It really speaks to structures and processes. It tells you who needs to be on call, how they have to respond, who needs to be part of the trauma team, a whole bunch of other things that need to be present. And it speaks to what you need to be doing, but it doesn't actually ask for any level of quality of care. It asks for a robust PI program, but doesn't say you have to achieve a particular level of performance. So TQIP is the bottom part of this triangle. Okay, so we don't necessarily focus on structure. We do look at processes because we're interested in them, but we focus on outcomes. We provide information about trauma center outcomes back to centers. The other way you can think of quality is these 6 dimensions, which are disseminated through the World Health Organization. And TQIP speaks to 4 of these. So accessibility, you want to get to the OR promptly. Effectiveness, are you doing the right thing? Are you avoiding harm by reducing complications? And we provide information back to centers about their resource utilization as well. We don't speak too much about patient-centered care, although I'll speak to this a little bit tomorrow in another talk. And we don't speak to equitable care. But these 4 dimensions are considered to be very important, and we feed that information back to trauma centers. So when you think of trauma quality improvement, when you think of what most of us do, the traditional approach is identify cases that went awry, identify sentinel events, review those cases in great detail. You might compare this year's performance to last year's performance, and if the PE rate is the same as last year, that's considered to be okay. And there's focused case reviews. But really, this speaks not too much into the realm of quality of care. You can be following your mortality rates and PE rates and other rates year to year, and if they're consistent, that means they're consistent. It doesn't mean you're actually performing at a very high level. It just means you're pretty consistent. You can be consistent good or consistent bad. So there's other ways of assessing the quality of trauma care, and one way that most of us do this is the use of TRIS. And in many of our registries, we're able to estimate the number of unexpected survivors or deaths based on TRIS. Who has TRIS in their registries here or uses TRIS? Okay, so a few of you. So there was a nice paper published through a group from Pennsylvania asking whether TRIS was an anachronism. Is it outdated? And what they did was they looked at the state of Pennsylvania trauma patients, so they have a large state registry, and they used TRIS, and they applied this to their patients on an annual basis from 1990 all the way to 2010. And this is the observed to expected mortality ratio. So a number that's less than 1 means you have fewer deaths than expected. That's a good thing. And all you do is you apply the same TRIS equation to patients over time, and you have more and more unexpected survivors. And the reason for that is that medical care has gotten much better over the last 2 decades, 3 decades. TRIS and the TRIS regression model to predict outcomes was developed in the late 1970s, early 80s through the Major Trauma Outcome Study. So essentially what it's doing is predicting your current mortality expectations based on the experience in the late 70s, early 80s. And so much has changed, it's not really a valid comparison. Nevertheless, many of us still use TRIS. So this is a study we did several years ago, published in 2008. And we took all the centers of the National Trauma Data Bank, and we used a risk adjustment model that allows us to compare outcomes across hospitals. It allows us to compare apples with apples, because all trauma centers see different types of patients. And what you see here, again, on the y-axis, is the observed to expected mortality ratio. If your observed to expected ratio is 1, that means you're functioning just as you're expected to function. So these centers over here, each line represents a center. If the center is completely above the line, the orange line, that center has higher than expected mortality. So there's a bunch of centers over here with higher than expected mortality and a few over here with lower than expected mortality. Everybody else is average. And don't forget, all of these centers, for the most part, are either state or ACS verified, so they all have the same structures and processes, but their outcomes are different. Again, this is mortality. So it would be great to know what these centers are doing, so these centers could learn and bring their mortality rates down. And that's sort of the underlying foundation behind the American College of Surgeons Trauma Quality Improvement Program. So we started off as a small pilot study in 2009, became official in 2010 with 65 centers, and now we have almost 300 hospitals participating, as well as a large number of pediatric hospitals that are just joining with a new pediatric TQIP. There's centers participating from all over the United States. I think we have 3 in Arizona, and 1 in Canada, and 1 in Qatar. And at the last meeting, there were the South Koreans were interested, and Taiwanese as well. So it's going to be interesting as we compare trauma care across countries. So what is ACS TQIP? Well, it starts off with valid, reliable, standardized data. So these are data from your trauma registry. We do risk-adjusted performance measurement, and we feed this information back to you in the form of these reports. And I'll show you what a report looks like and how they're meaningful. We like to explore the variability in outcome to understand what the high-performing centers are doing. And I'll go through some of that both today and tomorrow. But when you have all these hospitals, and some are doing something different than others, the only way you pick up on that is first looking at their outcomes. And you go, oh, what exactly did you do differently, and what's different in your center compared to other hospitals? So we try to explore the variability and understand what's different. We promote the structures and processes of high performers. So if someone has unwittingly found something out really cool and they're doing it in their center, then we want to tell other people about it. We monitor performance and the loop continues. So this way all the centers get better over time. So this is what we provide back to hospitals now. This is what we call a caterpillar graph. It sort of evolved from the last one you saw. And you'll see here, these are the centers that have higher than expected mortality in this case, centers with lower than expected mortality. And, of several hundred hospitals, there's only a small fraction that usually are either have higher than expected or lower than expected mortality. So about 8.5% of all hospitals have lower than expected mortality, but 15% higher than expected mortality. So most hospitals, as you would expect, are average. So what have we learned? Well, we've learned that it's very challenging to identify what's different about high performers, because you can talk to people, you can visit the hospitals, you can interview people, and because everyone lives in their own world, they don't realize they're doing anything different or unique. So it takes a lot of time and effort to explore this and try to understand what's different. We also found that no single center has figured it out, and I'll show you some graphs of this. Everybody has their own area for improvement and their own areas where they excel. And as you start picking apart why this center is really good at this, you realize they're not so good at this, and they can learn in this area, but they need to tell other people about what they're doing that's really, really innovative. So nobody's good at everything. And this led to the concept of TQIP cohorts. So we provide information back to hospitals, not only on their entire trauma population, but we slice and dice the patient population so you know where you're strong and you know where there's opportunities for improvement. And we found that to figure out what centers are doing right, we have to do all sorts of things. We have to, again, interview people, we survey the centers, we look at specific processes of care, we do a variety of things to try to get something out of these centers that are doing something really unique. So this is what hospitals see. They see this as part of their benchmarking report. And I'll just go through this slowly with you, but this is the odds ratio of a particular outcome. In this case, it's mortality. This represents an odds ratio of 1. So if a center is touching this line representing 1 over here, they function basically as expected. So this particular hospital, this line over here, which represents them, has an odds ratio entirely above 1. It means this center, it's red, it made it clear for a reason, has a higher than expected mortality overall. But it's okay for blunt multisystem, for patients who present with shock, for TBI, at the higher end there, but it's okay for TBI and a more severe form of TBI. But look at the elderly patients. So if you try to understand where they're doing poorly, this is where they need to focus their effort. They're okay with elderly blunt multisystem, but the little old lady who falls, this is isolated hip fracture, they have a problem as well. So what's likely driving their excess mortality here is their care of the elderly patient. And this is something we've seen. I'll tell you, most of us, when we first went into trauma, and Peter can probably speak to this as well, it was a very exciting time when I was going through my trauma fellowship, a lot of knives and guns, and it was really exciting. And our population has changed. Now we're caring for people in their 80s on a variety of different oral anticoagulants who are up on the roofs doing stuff and falling down, and we're not really all that well prepared for that. And we're trying to change the flavor of trauma care so we can better address the needs of the elderly. But this graph in front of you, this figure, is very typical for trauma centers because we figured it out. We know how to resuscitate the young, healthy individual. We're not so good at the elderly. And this is a study we did asking whether, if we're good at taking care of the young patients, are we actually as good at taking care of the elderly? And we're not. So what we did was we ranked centers based on their performance. So these centers that are a rank of 1 are the best performing centers, the worst performing centers. And this is for young patients, this is for elderly patients, and it isn't a great correlation. So you can be good at young, but not so good at old, and we see this quite commonly. This is another way of looking at it. So this is whether centers are good for young patients. They're either low performers, average performers, or high performers, and this is for elderly. And what you see here, if you're a low performer for the young, okay, you're probably not going to be a high performer for the elderly. If you're not good at taking care of young patients, you're probably not all that great for older patients. They have less physiologic reserve, and they don't tolerate things if you do them improperly. If you're an average center, you're probably going to be average for both young and old, but there's a small fraction of centers that are actually doing something different for the elderly that's helpful, and some that aren't so good. And if you're a high-performing center, there's a better chance you're going to be high-performing for the elderly, but a lot of the high-performing centers for the young are not necessarily high performers for the elderly. So it speaks to the fact that we probably need to evolve our trauma care to better take care of this patient population. And I see there's a lot of posters that speak to care of the elderly because we're all learning how to do this properly. We developed these best practices guidelines to address some of these gaps, and these gaps really speak to who the trauma team should be activated for, how we address perioperative care in a very directed way, how we manage all those new anticoagulants, which have become everyone's major problem these days, Beer's criteria, what meds you should be avoiding to prevent delirium, which adds days onto your length of stay, and the value of proactive geriatric consultation. I can speak to all of these if you want, if there's questions. The other thing, there's the other end of the spectrum. So I demonstrated earlier that if you're really good at taking care of young people, you may not be so good at taking care of old people. We're moving forward with pediatric TQIP, and we're exploring the differences between adult and pediatric trauma centers. And what we found is that when you compare outcomes between adult trauma centers, mixed trauma centers, which basically have they're designated as both pediatric and adult, or pediatric standalone centers, there's significant differences in outcome. So if you look at this represents the odds of death for children in adult centers versus a pediatric center. So this first line over here, 1.57, this is basically all the way over to the right, doesn't touch the line. This demonstrates that if you're cared for in an adult trauma center and you're a kid defined here as less than 18, you have higher than expected mortality than if you're taken care in a pediatric center. Mixed trauma centers, the effect isn't as profound, but again, kids do best based on these data in pediatric trauma centers. We stratified it by age. So in pediatric centers, so in adult centers taking care of young kids, age 0 to 5, there's a higher than expected mortality. The effect isn't all that clear for kids in the 6 to 11 or 12 to 18 range. So it looks like there's an effect at the other end of the spectrum as well. Adult centers probably need to learn a little bit from the pediatric centers about caring for the young children. They're probably fine for the older children, fine for the adolescents, but there appears to be differences when you look at the young children in the 0 to 5 range. This doesn't mean that 0 to 5-year-olds should only go to pediatric centers. It means the adult centers who, by virtue of their location and geography and how the system is set up, need to figure out how to better take care of this particular population if they're going to be doing that. So we're exploring a lot more of this. I can tell you there's interesting differences in the approaches to imaging. If you take the same kid, you go to adult versus a pediatric trauma center, the rate of imaging is very different. The pediatric centers really are capable of imaging at a far lesser extent than adult centers for the same types of injuries and getting away with it just fine. So a couple more slides about what makes a high-performing center. So a little bit about organizational culture. So what is organizational culture? We live it every day when we go back to work. It's a system of shared meaning held by members that distinguishes one organization from other organizations. So we don't really appreciate culture when we're at work, but it's what makes us feel good about what we do and what makes us perhaps not feel so good about what we do. We try to evaluate culture across the TQIP hospitals, and we developed this Trauma Center Organizational Culture Survey to try to identify centers with healthy cultures versus unhealthy cultures. And we validated this through 144 different trauma centers and over 2,000 respondents, which means there were many respondents in each of the hospitals. And we had 44 questions that were ultimately collapsed into 3 different areas. And the respondents, again, covered a wide variety of individuals. You can see here nursing was represented, ICU, ED, ward, advanced practice nurses and OR nurses, docs, including emergency medicine, surgeons and anesthesia, program individuals like registrars, trauma coordinators, and performance improvement specialists, and then leadership, trauma program managers, administrators, and trauma medical directors. So I've got a wide variety of respondents to the survey. And this is what we found. We collapsed the findings into 3 different domains. One domain referred to as opportunity, diversity, and pride. Make sure everybody feels good about what they do, and they have the opportunity to move forward in the organization. It makes people feel good about what they do. And the average score on a scale of 1 to 5 was 4. So the center's overall pretty happy about opportunity, diversity, and pride. They were also pretty happy with their trauma center leadership, which really is their impression of the trauma medical director to a large extent. There was probably some opportunities overall in the employee retention and reward category. So there were individuals who perhaps felt they weren't getting the attention or reward they were getting given all the time and effort they were putting into taking care of these complicated patients. But this gives you the sense of the scores in these 3 domains. Interesting, though, when you look at how the leaders responded versus everybody else, the leaders had a higher perception of their culture than everybody else. So leaders perceived the culture to be healthier than it really was. Again, a small number of leaders responded to the survey. They all thought that their centers had a healthier culture than the people who actually worked at those centers. Whether you look at opportunity, pride, and diversity, leaders are in blue, non-leaders in red, leadership, and a big difference for employee respect and recognition. So most of us are on the rank and file. We're taking care of these patients every day. We probably have a better sense of what the real culture is like than the leaders who think there's a positive culture because they're the ones who are disseminating that particular culture. So interesting differences between leaders versus other. Also big differences between administration, physicians, and nurses. So the administrators, again in blue, always had the most positive perception of culture. Physicians, a little bit less positive, but positive compared to the nurses who had the worst impression of their local culture. So interesting, the closer you are to patient care, the more differently you interpret your own culture in your organization. Okay, so the further you are, the closer you are to the C-suite, the further you're removed from what actually happens at the bedside. Well, how important is this? So it's important. So this is the relationship between mortality and culture. Okay, so what you see here is these are scores representing or the impact of the perception of culture on outcome. So if you have a red bar, then the relationship is positive. That means you're going to reduce mortality. So non-leaders here, if they believe that there's a lot of employee respect and recognition, trauma center mortality goes down. Again, the red is the non-leaders, the blue are the leaders. So the leaders think there's a positive culture. There isn't, but them thinking there's a positive culture and it not actually being the case increases trauma center mortality. So that disconnect between those who work at the patient bedside and those who work in the executive offices that are nicely air-conditioned, beautiful art, nice lighting, and so on, unfortunately, they're living in a different world than most of us. and that difference impacts on mortality. So if the rank and file, if people working by the bedside have a positive sense of the culture, then trauma center mortality ratios go down. The same thing with complications. It's even more profound with complications. Again, leaders are in blue, non-leaders in red. If you have a lot of employee respect and recognition perceived by those who work at the bedside, positive impression of leadership, opportunity and pride, or total score, you're going to have lower than expected mortality. If only the leaders believe this to be true, you're going to have higher than expected mortality. So it speaks to a very important finding here that sometimes there's a big disconnect between what happens at the bedside and what happens in the executive offices. And this is probably the most profound finding we have found in TQIP. I'll present some other findings tomorrow. But it's interesting how this particular assessment of culture gives you a good sense of what needs to be addressed. Unfortunately, culture is very hard to change. You can't just go ahead and put a protocol of culture, a positive culture in a hospital. Culture takes time to change. And this is a very interesting paper. So Ken Kaiser asked the question, what's a world-class medical facility? So Ken Kaiser was the Undersecretary of Health for the Department of Veterans Affairs in the 90s and was credited for the turnaround of the VA hospitals. And he asked a simple question. It's a 3-page article. It's worth a read. So what's a world-class medical facility? In industry or sport, it's when you get really good service, if there's outstanding performance. It's a level of performance that ranks among the best in the world. That's what world-class means. Well, what's a world-class medical facility? So it's a good question, but when the Walter Reed National Military Medical Center was being built, this probably dates, I guess, from 2005, there was a need to rebuild, and you probably know more about this than I do. I'm a Canadian. Congress mandated that it be a world-class facility, and there was a problem because there was no definition of world-class. So there was concern that it can't possibly meet the definition of world-class without some direction. So there was a series of experts who were brought in to try to define what world-class really meant. And world-class, ultimately, through these experts, was defined in 18 different categories, 6 different domains. And in essence, this spoke to what needed to be built into the hospital, what kind of people needed to be there. Really spoke to the layout of the institution. Okay, so that's how world-class was defined when the center was built. But what Ken Kaiser goes on to say is that what they missed is what's called the invisible architecture. And it's the invisible architecture that represents the values, culture, and emotional climate that's critical to turning a concrete structure into a world-class facility. It's not the building, it's not the resources, it's the people, it's the commitment and the passion that people have when they go to work every day and provide care at the bedside. So really it's above and beyond compliance with standards to bring the best of the art and science of medicine together. It's professionals working together as a team with precision, passion, and a commitment to excellence. It's much more complicated than having the right protocols and procedures in place. It starts with having the right people who have a lot of commitment to what's being done every day. And I imagine because you're here today, you have that commitment. So what I would do, what I ask you to do is when you go back home to and provide care to these complicated patients, that you think about this a little bit. It's really commitment and the passion that you bring that makes a difference. And don't be afraid to speak up and provide insights to those in the executive offices about what needs to be done to provide better care to patients. And just one last reminder that we're all striving for perfection. We're never going to get to perfection, but if we chase perfection, we can catch excellence. And with that, thank you very much for inviting me.